I know that you're tired.
We're excited.
But I'll try to keep you. I was asked to say something positive because it's very depressing. You know, just when the lady was talking about the child, that, you know, and exposure therapy and how it made the child be able to go to school, it's just warm your heart. You can't really not be happy. You know, you took a child that you really like, you know, shrinking and afraid, and suddenly you can go back. What is more exciting than that? So don't forget about, like, this morning, got an email from, you know, one of my residents doing PE, and he just say, you know, patient discharge, and he wrote him a testimony that he's in a different place because of the trauma that was so bad. He said always he had like split personality, one like hovering above, looking down at the event, and there was no emotions. And the end of the therapy, he said, I can now look down with all the full of emotion. It's just, I'm totally different person. You know, no matter, like, he had to first separate himself, look at himself from outside, but suddenly he's have this emotion. So when it works, when you're helping patients, it's a miracle. You can do miracles. Okay, so keep the optimistic part of it. So we're not going to talk about treatment resistant. We're going to just excite you in new directions. I'm bad with this clicker. So quickly, you know, in the US Veteran Affairs, we try at least 50% of the patients are getting psychotherapy. Not like Ukraine, most of our veterans are being medicated, about 50 to 75% of the veterans getting medication. Here I know that you're much more engaged in psychotherapy than deciding medicating patient, and it's really, really amazing that psychiatrists spend the time doing psychotherapy. I'm so excited to be so, and a lot of them involved in some level of counseling, vet centers, supportive psychotherapy. So the problem is PE, a lot of people drop out. They cannot finish either from any, and we know that SSRI, SNRI, we have only 30% monotherapy success, but we still give it in large amount. Okay, so I want to talk about ketamine, because we just did ketamine. But I want to put a cautionary tale, because in China, you know what is the number one party drug? Oral ketamine. That's the number one addictive drug in China, the most popular drug. So remember that. Matthew Perry, the star of Friends, gave him intramuscular ketamine to deal with his depression, and eventually he got heart attack when he was in a jacuzzi. It's so, okay. So it's used safely, okay, in sedation and acute agitation in emergency setting, treatment of chronic pain, and treatment reduces depression. But remember, there is cautionary tale, so we really want to keep it in our back of our mind. We want to use it safely, and we want to make sure that we're not creating a new addiction, like the opiate addiction that happened. So, again, what happens now, it's approved by the FDA to treat treatment-resistant depression after people fail a 200-person trial. That were with adequate dose and duration, and there is evidence of lack of efficacy. Okay, so they get either 0.5 milligram per kilogram IV for 40 minutes. That's the antidepressant dose. Okay, or they have nasal spray. I think the 56 milligram costs like 700. The 84 costs almost $1,000. I don't know the prices, but very expensive drug. But it's a nasal spray, and you're doing it twice a week for 4 weeks, okay? And then you go into maintenance once a week until you are being, the psychiatrist decide that you can go off the medication. And but there are risks, of course. And I just have to rush because they want you out of here by 5, so I'll move faster. So here's the trial, the ketamine trial, and this is the results that you see the relapse rate. This is patient without relapse. People that not relapse, 60% did not relapse on the ketamine for MDDs, and this is oral antidepressant, regular. We have about 40% not relapsing, meaning 60% relapsing to MDD versus only 40% in a ketamine. So this is now approved for ketamine and this protocol. But again, a cautionary plate, a lot of people that coming to our trial for PTSD already have experience with ketamine. So they're looking an other opportunity to get it because it's really make you feel good. So it's reducing the depression and suicide thoughts. So there is a good things there. So the largest ketamine for PTSD trial was done in our VA, and they compare low dose 0.2 milligram per kilogram versus 0.5 milligram per kilogram, and the placebo was saline, really saline. People really just got salty water and that was the group. It was 3 infusions 3 times a week for 2 weeks. So a shorter protocol. And what you see is that there was no difference in PTSD symptoms reduction at the end of treatment. That was the 2, I'm mixing with Mount Sinai and PTSD. There was 2 infusions for weeks, 2 times a week for 3 weeks. You see no difference at all between the PTSD symptom between the dosage, even saline. So they concluded that ketamine alone is not sufficient to treat PTSD. However, what was interesting is you see here, this is actually the lower group. The lower amount, 0.2 milligram per kilogram, was kind of the rate of improvement was higher than in saline. So you can measure the rate of improvement. That was significantly faster than saline, but not from the other drug. If you want to squeeze the data more, you can always find a way to, and they found that 8 weeks after the treatment, if people improve at least 25% improvement in their symptoms, the 0.2 milligram, the low dose, was more effective than placebo, but not from the 5. But that, when you're skidding, you're creating something that you find a signal. So that was the higher dose at the end of treatment was much more, reduced depression symptoms significantly more than saline. So yeah, the antidepressant effect was there. So again, it helped depression. The conclusion was that it's not by itself sufficient for PTSD. But why ketamine was interested for us in combination with psychotherapy? Because we talk about this situation that after prolonged stress like soldier, you have really atrophy in the synapse and on the neural level, okay? So this is loss in dendrite spine and loss in branches after prolonged stress. After ketamine infusion, 24 hours, there is some level of neurogenesis. You can see this is a real picture from the microscope Okay, this is before the ketamine infusion, and this is 24 hours after the ketamine infusion. You see, So ketamine is, show, again, cautionary tale in animals. Because he's going to kill me. He's a very safe psychiatrist, and he wants me to be cautious. I'm cautious. All the neurogenesis is in animal. Single study in our pet. I said there was a lot of manipulation of data, so I'm not going to present it. But there is evidence that something happened in the synapse levels, and there is some neurogenesis, synaptogenesis, and cell proliferation. There is a lot of excess of glutamate in a postsynaptic level, and there is a peak in BDNF that are probably associated with that. Also in animals, it shows it's really facilitate fear extinction in animals. Again, animal models use the same. Oh, I'm talking very fast. I'm trying to finish fast. So, it's always we use the same model for chronic stress, depression, PTSD. It's all the same models in animals, but everyone that's doing the research applied to their own diagnosis. So, so we have a protocol because we thought, 24 hours after the infusion of ketamine, we're expecting some positive antidepressant effect. If you remember, the dramatic decrease in depression symptom is 24 hours post-infusion. There is really strong reduction, and we know that BDNF level returned to baseline after 7 days. That was already tested. We have blood samples, and we know that we're about the time frame. So we say, let's use the 1 week. There is some changes induced by ketamine to do an intensive PE. 1 week. Not 2 weeks, not a month, 1 week everyday PE to harvest, to take advantage of the ketamine potential result. The actual protocol is 2 infusions. This is the pilot that funded the grant, and we had only 1 infusion. But we were asked by the reviewer to change and add another infusion on day 4. And we also asked in the new trial that we're running, and we already have 60 patients, but it's still blind, so I cannot share the data, to use the 0.2 milligram compared to 0.5 compared to active placebo that we have midazolam. Actually, so you come in, and the NIH wants biomarker. You want to see something changing in the brain, in the blood, and something that will be an indicator that something changed. So our indicator is amygdala activation to the trauma script. And we do MRI, you need to compare it to something. So, compare to what? So the baseline is listening to a neutral script, and then you see how much above the amygdala is being activated from the neutral script. And we also had set script. I'm going back. We also had set script because I thought, remember, I wanted to make it as said memories. We don't want to make it funny or neutral. So we wanted to see, changes in that direction. And we follow people 30 days. We did another scan of MRIs. And we did another scan 90 days. So 30 days post-treatment, the scanning showed significant decrease in distress when listening to the trauma script in those individuals. So when they listened to the script, they were experienced significantly less distress. The amygdala was less active when listening to the trauma than the midazolam group. Going the wrong direction. When we look at the hippocampus, I cannot read. This is a hippocampus. Again, significant decrease in the amygdala, the hippocampus activation when listening to the trauma script. When we look at the prefrontal cortex, and again, remember when we're doing memory reconsolidation in prolonged exposure, we want to create a new memory. And I don't remember if I presented it on the first day. The idea that you don't need anymore to put the brakes on, because I talked like 50 times about two different systems. Overgeneralization of fear, that you're afraid. Shelley showed you the bear, the cookie, Pavlov. That's something else. This is when you are afraid of things that you don't. The treatment in PE, we're rewriting the memory, we're creating a story. Remember I showed you it was activating the PCC. We wanted a new story in the hippocampus. We don't need, like in overgeneralization of fear, to press the brakes. It's a story. Okay? It's not fear, it's uncomfortable. So we didn't see differences because we thought PE working well, you don't need to put the brakes anymore in a VMPFC. What was interesting is also we saw the functional connectivity while listening to the script was reduced in the ketamine group. So when you listen to the script, there is less this kind of communication between the story, the new story, and activating the amygdala, that you need to be afraid of it anymore. So that was significantly lower in the ketamine group than the midazolam group. We did like some, everybody play machine learning. So we just learned half of the machine, half of the sample we put into training. We say, you see, RSA is a cool, you see, not, okay. When you're measuring average, you take the amygdala and you just take all the voxel in the amygdala and average them together. When you do RSA, response similarity analysis, you see how each voxel dents during the time. You take the area, so I'm just making up, 252 voxel. How they moving? Okay, I'm just made it up a number. Okay? And then, based on the way that the voxel were dancing through the listening to the trauma versus ketamine versus midazolam, they danced different dance. So the machine, after we gave them a say, can you tell me if this was ketamine or this was midazolam? So based on the amygdala activation to those response, we are like 73 accuracy, 70.3% accuracy level, quite good for the amygdala and hippocampus activation. So we know that the drug affects those areas differently. How people did in treatment? Very well. So you saw they started in about mean average of almost 46. And if the median was 50 on the PCL, 90 days post, they were at 31 average, 27 median. So very robust effect. But when we asked about symptoms, we couldn't find differences between the group. So you have that's why it's so hard sometimes to measure symptoms, because people report verbally different things. We did quickly one more analysis because you know what galvanic skin response, we sweat. When we get stressed out, we sweat. You can just measure the currency, how electricity flow through the body. So you sweat more, the electricity move better than you sweat. So that's another measure of distress. We saw when people listened to the trauma script, they were less stressed out. If they received ketamine, we're talking 30 days after treatment. The wash up of the ketamine far after that was much better than, less distress in the ketamine group versus midazolam group. Again, thanks God that NIH doesn't interested in symptoms, will not get the grant. They just was interested in a biomarker. So hopefully we have a site in Israel the treating soldier, and we have a site in the US in here. And we'll have eventually 160 people treated in that treatment, and we hope that we can give you more. But this is emerging. It's not proof. The only proof that we know that it's ketamine alone doesn't work. Maybe because of the potential brain changes, we have an opportunity to create it. And I want to stay very true. It's about a fifth of the dose that people get in the antidepressant protocol, if you take account into the maintenance phase. So we want to keep it the minimal amount of dose necessary to create a change. So quickly, we're going to split the time. Quickly also talked about neurofeedback, and I know that you're doing neurofeedback. When we're doing without control, it's very hard to measure because always we believe in it's look great, but here we have a control group, so we know that. So we have a real-time amygdala. Again, amygdala is the measure of stress to the trauma memory. I'm using trauma memory because I'm interested in memory change, memory reconsolidation, and not the overgeneralization of fear. This is Michelle, she is a world expert in real-time fMRI, and she set up the system. When you listen to the trauma script, you will see on the screen, you will see the trauma, the amygdala activation. So first we wanted to capture the amygdala area that respond to the trauma because it's different in any individual. So you came for a session for, it's called localizer. You coming, you listen. We had 5 versions of the trauma script, so it will not be similar, okay? And they will listen, they were resting state, then they do counting back, and then there were 60 seconds of we localize it. Where is those areas specifically in the brain? Those areas in the program were then shown up on the screen when they come. Okay, so then come, again, resting state, you counting back to just, you want to make sure that you're ready. And then you're listening to the trauma. And what you see, I'll just give you the dosing. There was six training trial in each time they come to the MRI. They came a week apart, so and then was 3 visits. Only 3 visits, okay? And then each visit was included 6 trials that you downregulated. You see red, one is before the experiment. Red is when you listen to the trauma. We say, listen, don't do anything. Only when you end, you need to try to downregulate the response and try to control it. So this is the neurofeedback. You are learning to control and not to be afraid of the memory. You know that they are so afraid of it. And then you're teaching them to downregulate it. And we see that people that got the control was sham, meaning they got a signal, but it wasn't their signal. It was a fake signal. It can be very frustrated. You're doing stuff and it's not working. So the sham group, and you see that people with the neurofeedback were much better able to control the amygdala, and you see that they had much better reduction in CAP scores. So it was a really strong 42-point reduction in the CAPs in the 60-day post-treatment versus 25. There was a very chronic patient that we treated that were not responding to treatment, and that was kind of a, and maybe we thought this is an opening window to now that they know to control the memory, they can go to PE or other treatment. This is not necessarily the holy grail, but this is kind of a very interesting study. And I know that we're talking about MDMA. MDMA is 2 minutes, okay? You have a prep session. We're not doing the MDMA trial right now. I'm just sharing you the protocol, the maps, now Lycos. You have a preparation telling you how you're going to feel and preparing you to the study. And then you have 3 8-hour 3 8-hour dosing session, okay, approximately 1 month apart. And they have a therapy that they developed that you're sitting with the patient while they are high on the drug effect, okay? They were dosing the first session was 120, and then the following session was 180 milligram. So they show effect size of 0.7 in phase 3, that significant reduction in PTSD symptoms in the MDMA group compared to placebo. But again, FDA did not approve it because there was issue about blindness, because placebo was really, and how you do 8 hours of psychotherapy with people that are on placebo. And other issue that came, that study was mostly female. Majority of the people in the trial were female, and our VA is very interested to see how it's affecting veterans. Most of the people have prior experience with the drug, so they know that they're getting the drug. And when you listen, there was a sense of people that really interacted. It was like a cult. The therapists were a cult. They were so self-believer. They were so biased in the way that they themselves approach it, so they can influence outcome. And they also, there was kind of evidence that they try to convince the patient this is the best thing that can happen for them throughout the trial. Okay? We don't know what the drug effect by itself alone is, so it's just another question by itself. And I wrote don't know what the drug effect, and the small group of people, and it was very interesting that I think it was underreported. So if you thought that you're getting MDMA, and there was a very small number of those patients, but you didn't get MDMA, those small groups were not different than the group that got the MDMA itself. So that was very hard. I don't know who's those people, but there were some people that thought they get MDMA because they were high from life. But they got the same amount of improvement, but that was a very small group. And again, it's not, so there is still way to go. But people do, we see in people across the globe that people respond, that allow them to access the memory. But the therapy itself that they implemented, there was touching, there was a lot of stuff that we don't know it's necessary. So maybe doing it with PE or combining it with something else will be appropriate. But the first stage is to know, like ketamine, drug alone work, maybe drug alone, or maybe it's me. But if you do it with psychotherapy, do it with a good psychotherapy. It was tested. So I'll let Noah present his amazing work, and he's staying away from drugs. He's a good guy. At the end, we'll ask. Thanks. Sorry.
That's okay. So what time should I be done by?
5.
3 minutes.
No,
3 minutes.
Until 5.
I may need a little. I may need a little bit more than 3, but not 2 minutes.
17.
There we go. Yeah. So I was just asked to end with some sort of exciting stuff that's coming out in terms of the research space. My other lectures, for those of you who are here, were really related to things that are established, that we have shown clear efficacy. What we're talking about here is research, although I'm going to show you some very exciting new results that were published actually earlier this year. We're going to ding. We've seen this before. So this is my hometown of Providence in Rhode Island. And we have an event that we call Water Fire, where we light up our rivers. And this is a salute to our military veterans. Not this year's picture, because it was just November 11th. But it's a very nice way that we celebrate our veterans and service members. So I always like to have this for a little table of contents here. I'm going to spend most of the time talking about our work in transcranial direct current stimulation. So I'm really going to zip through the other stuff. I spoke earlier about neural networks, so thinking about these illnesses that we treat as different manifestations of how the brain is not working the way we need it to work. And really what we're going to be doing here is leveraging this information to help get people better. I also showed you that when we stimulate the brain using transcranial magnetic stimulation, that we can change brain activity. These are in patients with depression. And so I want to show you what some of the work is when we do this in people who have PTSD, as well as depression. But I'm just going to show you the PTSD work. This is a very, very simple experimental protocol where we give people some stimulation and it's sandwiched between MRI scans. And so we see a number of very neat things. We can identify some brain signals that tell us who is more likely to respond to the brain stimulation. So we see areas, so we look at areas that are involved in post-traumatic stress. And examples of these areas are the subgenual anterior cingulate and the amygdala. For this conversation, we can just focus on the amygdala. And what this tells us is that those people who have a stronger connection between their medial prefrontal cortex, sort of a regulatory area of the brain, and their amygdala are going to respond better. So throw that in your head and hold on to that, because we're going to come back to that in a minute. The other thing that we see is a broad-scale reorganization of people's brains when they get better. And so I want you to focus primarily, and I call these mechanisms of response, how the brain changes when it goes from ill to well. And I just want you to focus on the hippocampus for a moment. So what this picture says with the little blue is that there's a reduction in the connectivity, or how two brain regions talk to each other. So there's a reduction from the hippocampus to the insula. That's where one of the little blue blobs is. And so what this tells us is that when people are getting better from their post-traumatic stress, there's a separation between their memory circuits, things in the hippocampus, and those parts of the brain that are finding the world to be threatening and more relevant. It sounds a lot like what my patients tell me when they're getting better. And we're doing all sorts of other work looking at different technologies to see these kinds of stories. So, but I want to talk to you about this particular technology, transcranial direct current stimulation, because this is something that I think is very exciting for us here, and I hope I can convince you of that in the next very short period of time. So we keep seeing this brain area, this medial prefrontal cortex, and I just put up some of my neuroimaging research here. And we get very excited about that area, as you've heard over these last couple of days, because this is the area that has to be working correctly for people to respond to prolonged exposure. This is the part of the brain that's helping regulate the amygdala. And so, and this is not a new story. This is back in 2007, showing that this is the area that has to work for prolonged exposure to be effective. So we get very excited about this area of the brain. Here, this is work I've done with a good colleague of mine, Masha Frank. And one of the challenges when I'm speaking to a different audience is that often I have to introduce ideas about extinction and memory and things like that. You've heard lots about that for the last couple of days. The core problem here is that people learn that certain survival skills are really important. They learn that again and again and again. It saves their lives. And their challenge is that when they go to a different context, they have to learn that this context that seems threatening, it's similar, is actually not threatening. That process is called extinction, and that medial prefrontal cortex is the area that needs to work for this to happen. Our problem is that that part of the brain is not one that I can get with transcranial magnetic stimulation. It's not accessible. It's too deep, it's in the wrong place, we have some physics problems. So what I've been using is this other technology, transcranial direct current stimulation, which I'm just going to walk you through so that we all know what we're talking about together. So first we're going to take a person. This is loosely modeled after me when I had no beard and had shorter hair. And we take a small current source, typically 2 milliamps, That's what you can get out of a 9-volt battery, if you've ever lit one. So it's very little amount of energy. To that power source, we connect an anode. That's where electricity comes into the brain. And we connect a cathode. That's where electricity comes out of the brain. And so what we've done here is we've created a very, very simple circuit that's delivering a tiny little bit of electricity into the brain. And then we have to ask ourselves, certainly I have to ask myself because I have lit 9-volt batteries, how can that amount of energy do anything therapeutic? And to answer that, I want you to imagine 2 different kinds of neurons. One are quiet, not involved in what we're talking about here, and the others that have some degree of activity in them. These are in the medial prefrontal cortex, but there's just not enough going on for them to work. You add a little bit of electricity to this system, not a lot is going to happen. You go to the other neurons, you apply a little bit of electricity, and you can help the neurons to fire when they otherwise wouldn't. So a little bit of some site specificity. And now we have to get the electricity where we want it to go. Perhaps. There we go. Okay. So what we do is we can do some fairly fancy modeling about where that anode and cathode need to be. And it looks something like this, where warm colors are higher concentrations of electricity. And I'm getting energy here in this picture into that part of the brain that I want, that medial prefrontal cortex. But it's not just about getting energy in. It's about getting energy in at the right time and the right context. And so Masha and I, over the last many years, have been doing a series of studies about this. And I'm sitting there. On one hand, I have a skin response electrodes, measuring how sweaty my skin gets. In my other hand, I have an electrode that's going to give me a shock. And I'm wearing a TDCS set up on my head. And you'll notice Masha has chosen to drive the machine while I get zapped. In this paradigm, every time I see a blue lamp on that screen, I'm going to get a shock. And this happens over and over again. So I see a blue lamp, I get a shock, I get a blue lamp, I get a shock, and sooner or later I start to sweat when I see that blue lamp. And then we mix it up, and I see the blue lamp, but I don't get a shock. And the amount of time it takes for me to learn that this blue lamp is no longer dangerous is an index of my extinction. Right? I learned that this context is no longer dangerous. And we have shown through a series of experiments that we can accelerate this process of extinction in young, healthy college students, also with patients with post-traumatic stress. Except that patients don't come into my office complaining about blue lamps. For this audience, I'm going to reduce some of the intensity of the next couple of pictures. So I treat veterans and service members on a regular basis. It's certainly not ethical or appropriate to send someone back into a dangerous environment, take them out of that, and help them figure out that it can be safe now. That would be problematic. But we do have this wonderful thing called virtual reality. And I know we have some virtual reality systems here too. And this allows us to put people almost back in these environments in a way that's believable enough. And so this is what our setup looks like. The virtual reality here has a goggles. On the chair rumbles, so It's haptic. That black box there shoots smells at you as well. In the beginning, we had people hold a rifle. That was too triggering. We don't do that. But it's a very immersive virtual reality experience. So what we did first, thank you. What we did first was a very small pilot study. Where people came in, we asked them lots of questions, and we did 3 sessions of stimulation or fake stimulation plus virtual reality, and then we did it for a second week. Everything identical. So 6 sessions over 2 weeks. And then we had them come back a month later. And so what did we find? So this is a skin conductance tracing. This is how sweaty someone's palm is getting. The little arrows on top are the virtual reality events, explosions, gunshots, what have you. You can see that this veteran is reacting to things very strongly. Really anything that happens, they're reacting to. After 2 weeks, everything is much calmer. People still react, but it's much, much less. This effect only happens in those people who got real stimulation, but not in those who got fake stimulation. We also started seeing some indication it was helping with symptoms over time. And so what we did was we had a follow-up study where we did almost exactly the same thing, which I'll walk you through. And then we really looked at people at 1 month, thinking that's where we might see the most effects. So this is the design for the randomized controlled trial that came afterwards. Really the only thing that was different was we had people come back 3 months later. So again, this is 3 sessions over 2 weeks. Everyone getting a standard virtual reality experience. It's about 20 minutes. And with real stimulation or fake stimulation. So what did we find? So this was published earlier this year in JAMA Psychiatry. This is the overview of the study. And what we found was that real stimulation was quite a bit better than fake stimulation, despite all of the other things that we were doing, with a clinically reasonable amount. The other thing I'll say is that people kept getting better at that 3-month time point. Although this was conducted during COVID, so I will say we had a lot of people who were not able to come back, and so we did lose quite a few people before the 3-month time point. But that's okay. So you might ask, did this also work on their galvanic skin response or their sweatiness? We clearly had 2 groups in the study. I'll call them Group A and Group B. Group A looked like this at the end. Group B looked like that at the end. That was the active group, and that was the fake group. So very clearly an effect of the real stimulation in combination with the virtual reality, with a very little amount of effort. So 6 sessions over 2 weeks with a virtual reality system and enough power from a 9-volt battery. People kept getting better over time. What we saw was the biggest difference in people's ability to function, however, took a little bit of time to see, which is also fun. This is a little bit different than what we see with transcranial magnetic stimulation, where we seem to see some functional improvements earlier. This seemed to be a little bit later. Why that is, I don't know. So let me wrap this up. We'll get done almost on time, but actually very close. So a few thoughts just sort of as I wrap this up. I think there's lots of very interesting ways that you all and we all can be thinking about how we both advance our care and understand the care that we give. So we can be following rating scales over time. I talked a lot about that with the folks who did the transcranial magnetic stimulation workshop with me over the last 2 days. I told you a little bit about some neuroimaging work, which is interesting. In my first day talks, I asked the question of, can TMS actually be used to do some prevention work? And I think that's a really important question. And I also talked to you a little bit about putting TMS machines in vans and moving them around. And what I hope I've shown you in the last 10 minutes is that there's another highly portable, easily scalable intervention that you can use for post-traumatic stress with virtual reality and transcranial direct current stimulation. And I think with that, I just want to say thank you.
So now question.
Now we can do some questions. Yes.
Any question?
Ilan, I have a question to you. Maybe I missed it because you were speaking so fast. Can you clarify the inclusion-exclusion criteria? Because I saw only 2, and I assume it's not only 2 of them. And a second question is about randomized groups. Can you repeat again?
Sorry. So the inclusion in terms of because it's 1 week intensive PE, we didn't take people with borderline personality disorder. I think you can change those people in a week. And we didn't take people with severe OCD. And if someone was using substances, active, we defined it as, I think, mild alcohol use disorder, and we allow people with cannabis use disorder because there are also almost all people with PTSD now because it's legalized using cannabis, so we had to really, and we looked at safety, so yeah. But if someone was using other drugs, they were excluded. But alcohol and cannabis we allowed if it was mild. And the other question was randomization.
Randomized group. Can you repeat again which groups you?
We had the midazolam. Midazolam we were either in the pilot study. It was either midazolam or ketamine 0.5 milligram or midazolam 0.0045 milligram per kilogram for the 40 minutes.
Did you have a group just with psychotherapy without any medication?
No, and we know that effect size is already around 1. And we didn't have to run also ideally the ketamine by itself because we know it doesn't work. So we're right now comparing that to active placebo. And again, we saw that midazolam did not interfere in the psychotherapy. You saw when I showed you the symptoms. They got all group improved very strongly. P is a very strong, I don't know if I will see drug effect at the end of the trial because again, P is a very strong therapy. I don't know, I'm blind. And again.
Thank you.
Будь ласка. На горі, отам самому. Як в нас був приз за краще питання, я думаю, що ця доктор би його отримала.
Я хотіла запитати на рахунок тих людей, які були в терапії з кетаміном. Чи помічали ви на своєму досвіді, що саме у цих людей підвищується емпатія, да? Тобто вони стають більш чутливими, але в той самий момент до ніби як чужої групи людей вони стають більш агресивними. Чи було таке і якщо було, то як ви з цим, в принципі, надалі працювали?
we didn't measure. We were blind. Shelley was doing infusion. Did you observe? As therapists, we were blind. I didn't know what this. I saw that patient after 24 hours after the infusion. Shelley was doing. Did you observe anything? You probably accept heart rate. Do you have any?
I'm sorry. Could you say that?
Did you see
That is
aggression, more aggression in people that receive ketamine, or more empathy, or anything?
No. Typically, what we saw was some nausea. People did feel a little paranoid sometimes, and a little anxious. In the acute, just coming out of the scanner. Often we would cover their eyes with a washcloth because they were sensitive to light. Nausea was really the bigger concern. It tended to resolve with 15 or 20 minutes. Within an hour, they felt back to baseline. But I did do several questionnaires as they came out of the scanner, and most of the time I did not see anything that was like psychosis or altering of perceptions, anything like that. It was generally reasonably well tolerated.
Дякую. І Олег, будь ласка.
І я дуже хотів подякувати. Це 3 дня було дуже крутих, але я коротко одне питання до всіх трьох. Що підказує ваша інтуїція як фахівців, що є найперспективнішим? Може, ми про щось промовчали, але для аугментації психотерапії при ПТСР?
Таке питання під зав'язку.
I like that Eli went first. All right, whatever your favorite thing is. No, I think it's important that we have a lot of options. There's a lot of individual stories. There's a lot of individual trauma. And there's a lot of individual humanity to each and every one of the people we treat. I don't think there will ever be a one-size-fits-all for this. I wish there was. That would make this a lot easier. But that's just not the reality of our world. So I think it's important to have a number of options so that you all can help figure out what the best thing is for people when they're suffering.
I would say also that some patients don't tolerate one therapy or another. Sometimes people are really not going to do well in prolonged exposure therapy, especially if they can't access the memories and really be able to speak about it. Some people don't like the format of cognitive processing therapy. So part of it is what you think would work for them, and then the other part is what are the things that they won't do. So having multiple options is going to be the best bet, again, because there are such varied situations for people. I don't really have a favorite. I like a lot of tools in my toolbox.
I'm just excited. There is so much yet to ask for, to learn. It's give me going every day. I think there is. We know that this maybe I told Ole and maybe the MDMA will be again after it will be out there. Again, we'll be stuck with 50%. There is no magic that works for all. But augmenting is important because maybe we can push it from 50% to 70%. That would be amazing. That would be kind of a new thing. And I'm excited about, TMS and the ability to recharge the prefrontal cortex. You don't need medication to block reconsolidation. We can use it by language. Maybe we don't need medication here. Maybe we do need medication. We don't know. We need you and everybody here to continue to do this research, and you do the wonderful work. Thank you, everybody, for having us.
Я бачу, що ви не хочете відпускати наших гостей, але я вам скажу наперед, що ми, наша клініка, наш центр Unbroken, вже домовляємося з ними, що ми побачимося на весну. Дасть Бог нам всім здоров'я, щастя і перемоги. Тому дуже вам дякуємо. Але знаєте, я потім прийшов хтось і всіх розігнав. До нас завітав наш генеральний директор і коротко тільки скажу. Це менеджер охорони здоров'я, який 4 роки тому прийняв рішення відкрити перше психіатричне відділення в багатопрофільній лікарні в Україні, центр ментального здоров'я. І це є приклад для багатьох інших, які сьогодні можуть або можуть це зробити. Так що дякую вам, Олег Валерійович, що і сьогодні.
Думкою на перспективу відкрив, так? Шановні колеги, дякую за ваш
Чути.
Колеги, дякую вам за те, що ви приїхали. 3 дня провчилися в нашому лікувальному закладі, отримали, я думаю, один з найкращих курсів в Україні і в світі. І завдяки нашим американським друзям і колегам, які працюють більше вже 2,5 років разом з нами, передають нам досвід, безкорисно,
Олег Валерійович, тільки не так, бо мене вас.
She's doing good.
Yeah, she's doing good. Even ahead.
Працюємо швидко, вже дуже втомилися. І ми хочемо зробити справді великий навчальний хаб, і не тільки по ментальному здоров'ю, по всіх сучасних галузях. Ця конференція справді чудова. Ви отримаєте найкращий досвід, ви його будете поширювати по Україні. І ми надіємося, що наша співпраця з нашими американськими друзями буде продовжуватися і далі. І справді не буде кордонів, які роз'єднані океаном, а ми будемо їздити до них, вони до нас, і ми зможемо справді надати якісну медичну послугу в Україні. І психіатрична служба зміниться. Ми всі знаємо, які в ній є плюси в Україні, які мінуси. Я, як минулий студент університету у Львові, бачив психіатричні клініки. Я хотів би, щоб наші колеги, особисто Олег Романович Борисюк, змінив повністю ставлення і зробив іншу психіатричну службу. Це не було якесь клеймо після лікування в цій службі, а щоб людина виходила і мала шанс на видужання, і ніколи не була асоціація з закладом, в якому вона колись лікувалася. Це все залежить від вас. І ми на це розраховуємо. Дякуємо вам, що ви нам допомагаєте. Дякую, що ви надаєте нам цей досвід. Підказуйте нам, ми раді завжди вас бачити. І дякую, що ви до нас часто приїжджаєте і підтримуєте наших колег. І діліться з нами своїми контактами, які у вас є, щоб наші колеги, ці всі, які такуються, щоб всі побували в вас і привезли цей досвід в Україну. А коли ми будемо сильнішими, ми поможемо вам. Ми ж разом з вами зробимо сильнішу медицину, я думаю, що рано чи пізно, чим в Канаді і в Америці. Дякую. Це вам на згадку прочитаєте про наш лікувальний заклад, про наші історії.
Thank you.
Олег Романович, це вам. Прочитайте про себе.
Okay.
Дякую вам дуже. Шановні колеги, наш заклад справді відкритий. Ми хочемо, щоб він був таким навчальним хабом. Ми зараз створюємо, ви скоро почуєте про Андропін університеті. Ми хочемо створити вищу медичну школу, де будуть різні напрямки для післядипломного навчання. І ми хочемо, щоб лікарі отримали найкращі знання, які можуть отримувати світу. У нас зараз є багато контактів, нам світ допомагає. І ми хочемо цими контактами поділитися і з вами, а ви вже будете кожен себе на своєму місці це поширювати. І тому що справді медицини кордонів немає, і всі повинні комунікувати. Немає областей, всі повинні спілкуватися. Дякую вам всім.
Я хочу продовжити шлях подяк, і ви бачите на нашому екрані, що це робимо. Дякую за те, що виділили пару хвилин. Воля фонд. І пані Юля, ви ще є серед нас? Можна до нас? Ми колись випадково зустрілися на каві. Так, пані Юлія? Я там не помиляюсь, чи ми... Матч. Бачите, яка це є добра справа. І пані Юля була зацікавлена в певних фонд, яким вона і директором працює в різних галузях, але це досвід психіатрії, психології, психотерапії, травми – це перше. Я сподіваюся, він нікому. І ми вам дуже дякуємо за те, що ви просто самі захотіли допомогти людям, які сьогодні тут працюють. і вони будуть допомагати людям, яких є просто дуже багато навколо. Тому вам дякуємо і читайте про нас. Ми також хочемо подякувати тим людям, яких немає серед нас зараз цю секунду. Це інший фонд, це фонд Unbroken Foundation. І, зокрема, Олександру Кобзарєву за те, що також нас підтримав і допомагає нам. Я хочу подякувати беззаперечно групі перекладачів Олегу. Олеже, дякую, ви працювали і беззаперечно найкращі синхронні перекладачці світу в медичній галузі, пані доктору Оксані Лизак з департаменту психотерапії, психіатрії Львівського національного медичного університету. Докторе Лизак, дуже дякуємо і приходьте ще. Також я дуже хочу подякувати від всіх нас людям, які технічно нам допомагали протягом всіх днів, але так їх не видно ніколи, але як бачите, ми не мали великих проблем, навіть якщо мали, вони швидко вирішувалися. Я хочу подякувати хлопцям і дівчатам, але особливо я хочу подякувати Дмитру, керівнику інженерної служби лікарні, за неймовірну підтримку, допомогу і відданість галузі ментального здоров'я. Беззаперечно, ми не могли б зробити цього без активної роботи Центру ментального здоров'я і психіатричного відділення. Я дуже дякую всім, особливо керівникам і доктору докторці. Так, правильно? Не скажу докториці. Докторці Божені. Божені, завжди скажеш прізвище? Андрущишин. І наступного прізвища я точно не забуду. Директору Центру ментального здоров'я, докторці Уляні Кремінській-Березюк. Особлива подяка нашому менеджеру Центру ментального здоров'я, психологу організаційному, це пані Христині Руді. І всім вам, шановні колеги, які приїхали сюди і залишились тут на 3 дні для того, щоб отримати, бо, як казав, мене 2 гіпотези, або у вас неймовірний інтерес, або ви дуже резильєнтні, але ще й третє. Коли мене перший раз запитали, як я почувався на тренінгу Єльського університету, а тепер ще і Браун університету, я сказав до цієї людини жартома: baby, it's a Yale. It's a Yale, baby. Я думаю, і це є також, чому ми залишилися тут на всі 3 дні. Тому що це потужна команда людей, яка знає, про що говорить, і знає, що ми хочемо чути, і знає, що нам треба чути. Тому ще раз велике дякую вам.
And I also want to make sure we mention Dr. Andrei Zinchuk in the back from Doctors United for Ukraine from Yale, because we're constantly trying to think of ways that we can assist and help move forward with the work we're doing. And certainly, Dr. Oleg Berezuk for his idea and his dream.
Що ж, дякую.
Adam, our photographer from Doctor.
Для того, щоб показувати більше людям через фундації, які є в Евангелії. Дуже дякуємо. Щасливо.